This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hello, and welcome to another episode of It's Not In Your Head podcast. I'm your co-host, Justine Feitelson, here as always with Dr. Dan Bates. Hello, Dan.
Good morning, Juz. How are you?
Toasty over here in San Diego. It does not feel like winter. 75 and hot.
Well, we're in Melbourne and it's summer and it does feel like winter. So, that's just the way we're off.
No, I'm not allowed to talk about it with all my clients who are buried in snow right now, freezing. And here I am in summer, basically. But we are going to keep going today with the various procedures that we've been covering recently on our episodes. And today we're going to take a deep dive into sympathetics in particular, which include things like stellate ganglion blocks, things that are related to the lumbar, pelvic, and also post-tib region with regards to stimulating those areas. So we're going to kind of break it apart like that. And Dan's going to take us through how he approaches and does each one of these under that umbrella.
All right. So sympathetic ganglion blocks. So the sympathetic nervous system is part of the nervous system that generally controls things like blood vessels. So it controls your blood pressure, it controls your sweat glands, has a role in controlling your organs. So, heart is a simple one. So the thing that makes your heart race is your sympathetic nervous system. And it's part of that whole flight or fight type system, so that when something or when there's a danger, your body sends out a set of signals via your sympathetic nervous system, and it essentially ramps everything up so that you can protect yourself, get yourself away from danger, and then it's supposed to turn itself off.
Right. And it's that automatic subconscious response with those different symptoms that if you have dysautonomia, for example, you can see already, that overlaps a lot. And if it gets out of control, what is that affecting down the line? And
so the sympathetic nervous system sits along your vertebral column, so along the vertebral bodies, and you can target it from a number of different regions. We generally will target something up the neck. We also commonly target the lumbar spine, and then we target the pelvic sympathetic ganglia. So there's a couple of different reasons to do them. So the main reasons that we see are complex regional pain syndrome. So complex regional pain syndrome, which Juz has a intimate knowledge of,
is near and dear to my heart.
A neuropathic pain syndrome that causes horrendous symptoms, of which many of them are sympathetic. And we'll talk slightly about those in a moment. Post-traumatic stress disorder, we treat with sympathetic ganglion blocks. And chronic pelvic pain is probably the other major one that we use for sympathetic ganglion blocks. Now, when you've got sympathetic nervous system involvement, when you're talking about a pain presentation, it can just be like normal neuropathic pain. So it can give you burning, can give you pins and needles, can give you numbness from the sympathetic nervous system itself. But sympathetic nervous system has specific symptoms. So it gives you symptoms of abnormal sweating in the area that it's supplying, abnormal swelling. So the thing just swells and goes away and then swells and goes away. And that's the effect on the blood vessels, because they get leaky and then they get not leaky, then they get leaky, then they get not leaky. What goes along with that is color change. So you get color change in the area. So it might go motley blue, or it might all of a sudden go really bright red, or
purplish, reddish.
At the other end of things, it goes white. So
pale,
pale.
It's like the Raynaud's response. And again, if you live with CRPS, you are already like a lot of overlap with that sympathetic component that drives that disease process.
And then you also get abnormal hair changes. So over a prolonged period of time, what you'll see is people get loss of hair in the area that the sympathetic nervous system is affecting in the area.
Yeah, thinning, loss of hair.
And so, what also goes along with that, if you then actually, interestingly, if you go on and did a bone scan, so a bone scan looks for bone turnover, what you can see is a decrease in bone density in the area. Now, that's probably got to do a bit with nerve function, but it's also probably got to do with deloading as well, because this stuff hurts a lot and people don't use it much.
Yeah, so some of the remodeling is sympathetically driven. Is that what you're saying?
Yeah, that's my understanding. When looking at the data on sympathetic ganglion blocks, it's generally pretty poor. Now, I think the reason for that is that by the time somebody turns up and they've gone through a million different treatments and nothing's getting better, by the time we get to that patient turning up, they're in a lot of pain.
That's the overwhelming tangled ball of yarn that one thing can only make so much of a dent in, even if it's an appropriate thing to use, especially when you have that PTSD psych component overlapping.
And so when you're doing studies in this area, you need to bring together a large number of patients. If you're not seeing now, to be honest, even with larger practices, you don't get tons of patients coming through with this symptom set. And so, number one, they're really struggling. And number two, if you're going to say, hey, I've got a randomized control trial going on here, let's put you into either a treatment arm or a placebo arm, and they're in agony. They're like, you think you're going to give me a placebo? I don't think so.
No,
so recruiting for a randomized control trial to treat these studies is really difficult.
And it's just not feasible.
Takes large numbers of patients. So I don't think we're ever going to see any large randomized control trials on the use of sympathetic ganglion blocks. There's some stuff within PTSD because there's the military component to it, but outside of that,
outside of the pain world,
so maybe outside pain world, but within the pain world,
that's the 3% of chronic pain is the weird stuff, and within the weird stuff is the CRPS and these type of things. So it then comes down to sort of your experience within your practice, like we've talked about with other procedures, figuring out how effective is it for that patient population, even if you can't refer to the larger studies.
So let's talk about stellate ganglion blocks. The stellate ganglion block is done at your neck. The stellate ganglion sits over C6, C7. It's the main sympathetic outflow from your brain. And so basically what's taking place here, we target it most commonly for post-traumatic stress disorder. I have also used it in patients that have generalized anxiety, that I do not feel that I can, get on top of their pain without getting on top of their anxiety. And so what's happening here is from a PTSD perspective, so in your brain, you have a trigger. That trigger sends an outflow to your stellate ganglion. The stellate ganglion then sends a signal to your adrenal glands. Your adrenal glands then squeeze out a whole bunch of adrenaline, and then boom, away you go.
Good time.
That's where you get the whole system. And so just like the rest of your nervous system, so we've talked previously about the peripheral nervous system becoming sensitized, the central nervous system becoming sensitized, like at your nerve root, then at your spinal cord, and then, further up into the brain. On the way back out, the sympathetic nervous system gets sensitized. Who would have thought? And so when the sympathetic system, particularly the stellate ganglion, gets sensitized, you can imagine that a little signal from the brain, you might go,
big response.
Trigger, big deal, hits the stellate ganglion that's really sensitized. It's like, I just got a signal. I better tell the boys to get some adrenaline going. Boom, big response. And so that post-traumatic stress disorder, you've got this very large outflow that's taking place. Now, of course, that's not the mechanism for everybody, but it's the mechanism for a number of people.
For some.
And it's those people that respond to the stellate ganglion block.
So this too is matching it to someone's pre-existing history, right? Just like when you're looking at what pieces of pain are you trying to address first, when there's these overwhelming pieces that are blocking someone from being able to take action and improve pain in other ways, this can be a really helpful tool to open that window for them when it is a big deal.
So the difficulty is, how do you pick that it's stellate ganglion
that it's sympathetic?
I don't know how to do that. There may be some people out there that do, and I need to learn, but right at this moment, I can't pick it. So the way we pick it,
essentially tests it with the procedure.
The way you pick it is you treat it and see if they get better. So when we treat it, what you tend to see is an improvement that takes place anywhere between immediately, because you've got a local anesthetic effect, and then it kicks in over 2 weeks. You'll then get an effect that will last for 3, maybe out to 12 months in some patients. For the patients that I see that I treat with this, interestingly, it's their partner that tells them to come back and get another one. They're like, you need another stellate ganglion block. Go back and see that. So I've got a couple of those patients. So
me too.
So I think that's interesting that, people external will notice before maybe you start to pick it up. So
yeah, but that's why external feedback is valuable, because you as a patient don't always notice it when you're juggling so many balls, and you may still be overwhelmed and you may still feel like you have so far to go. But that is, yeah, that's significant. People can notice it.
whenever we do a procedure, there's always risks. So risks for a stellate ganglion block are the same as usual. So infection, bleeding, bruising. Then what takes place is actually you affect the function of the stellate ganglion. So you're getting sympathetic outflow that also goes up to your face. So you'll get a little droopy eyelid on that right-hand side. Because it controls your blood vessels, your eye will go red. So you get one side of bloodshot eye, but all that sort of stuff just wears off as the local anesthetic wears off.
Yeah.
You also have the risk that if you get like a large amount of spread of the local anesthetic, you can knock off the laryngeal nerve, so you can get a croaky voice. Now, this one's really important because this is why you only do one side at a time. So if you do two sides and you knock off the laryngeal nerve on both sides, that means, the patient larynx, which is your air pipe, closes over and then they can't breathe and then they die.
Not
So
ideal.
don't do both at the same time.
Clinical pearl.
Yeah. Don't do a bilateral stellate ganglion.
Yeah, one at a time.
Generally, you'll start on the right side because of the wiring between the sympathetic ganglion and the brain. The strongest connections between the sympathetic ganglion and the amygdala, which is where much of this is taking place, is from the right side. But people are different. So some people have stronger links between the left side than the right. So if the right is ineffective, we then will consider to go on and doing the left by itself. There's more of a risk of some cardiac issues, so you can get heart changes on the left. So you just need to be cautious. We're always doing these in a hospital environment with our anaesthetists and the team around. So
if someone has CRPS, are you taking into account what side that affected limb is on?
Yeah.
So if it's
so if you've got a left arm, do a left arm. If you've got a right arm, we'll do a right arm.
Supersedes, the previous consideration.
Yeah, so, you've sort of stepped into the next bit. So what else would you use stellate ganglion blocks? So complex regional pain syndromes affecting the upper limb. I also use it in shoulder pain, in post-surgical shoulder pain. It can be quite effective because post-surgical shoulder pain is complicated and, it's currently my nemesis. I still got to work it out.
So in that context, you're kind of just calming the system?
Yeah. So shoulder pain, I think, particularly post-surgical shoulder pain, is really complicated and very hard to treat because you've got the brachial plexus. That is where all these nerves coming from your neck are then going down into your arms. The volume of nerves that go down into your arms, because of our fingers being able to do finger stuff, is so large that you've got an enormous amount of nerves going past that area. Yeah. And you start getting wind up of those nerves. Gets post-surgical neuropathic pain is really hard to treat. And anybody who's got it that may be listening does not like you touching them with needles. And they're like, do not come near me again. They're different to people with lower back pain post-surgically.
Yeah, well, it reminds me of people with thoracic outlet syndrome, which also kind of is very similar to CRPS and how it presents, how intense it is, that intrusive nature of it, and then how do you approach it once it's affecting so much function down the line?
And it'd be great. I'd love to say that these are a knock them out of the park, but they're not. They're they're one of those things that they add to, okay, let's see if we can dampen down this component of the pain and see how much gets better. So not perfect, but definitely a target.
Yeah, because you're doing it on, again, the more complex, highly wound up, long-term sensitization, amplification group of patients. So it doesn't move the needle as much necessarily as someone who has less stuff going on. It's more straightforward. You do the block, problem solved, because there's still more pieces left. But that doesn't take away from, its efficacy and how useful it is to get you going on the right track.
And unfortunately, by the time people are turning up to talk to us about it, where, they are years down the track. Yeah. I think it would be interesting
if you could do them earlier.
Yeah.
Is that your
through
thought?
the door.
Yeah. Like an earlier initial.
I had my shoulder surgery last, 2 weeks ago.
Almost preventative.
It's out of control.
Yeah.
Yes.
Or with CRPS, do it early if you can tolerate the stab. Yeah. Okay.
We're a long way off being able to do that.
One day. How is the recovery
Oh, the recovery from this is fine. There's no major issues. One of the things we've looked at doing for these and we do is pulsed radio frequency for them as well. So if you have a positive effect, that's really good but short-lived. There's a little bit of data around the use of pulsed radio frequency, which once again triggers off the release of anti-inflammatory factors from the nerves directly, and so decreases how sensitive they are. So a little bit of data around that. It's a way you can extend out the effect.
That's what I like that.
All right, so that's neck. The next main ones that we do are then lumbar sympathetic ganglion blocks. Lumbar sympathetic ganglion blocks, we generally target L3. You can do it bilaterally. The lumbar sympathetic ganglion blocks you are using generally to treat complex regional pain syndrome of the lower limb. And so L3 is where you get coalescence of a lot of the sympathetic nerves through that area, and you capture all of the lower limb. So risks, once again, same: infection, bleeding, bruising. It's interesting. You will get most people, if you've got the block right, they get a red leg afterwards. They get a red leg. That will last for, 2 to 4 hours, maybe up to 6.
Your leg is like warm and weird and
warm,
hot. Yes.
It's a bit sweaty because you've sort of altered that nerve function in that area. Efficacy, you're looking about the same, sort of immediate onset with the local anesthetic, comes on over a couple of weeks with the cortisone. Will last, 3-6 months when you get a good effect. I have a patient that has CRPS that responds really well to them. And actually, I got a couple that they turn up and they're like, okay, it's sore again. Can you please?
Well, and this was the main earlier procedure that I also did for lower extremity CRPS. So I did a number of blocks before working my way up to the spinal cord stimulator, which became a more long-term solution, because for me, the blocks started wearing off quicker and quicker, weren't lasting as long, weren't helping as much, but they were a big tool earlier on. That was probably the most significant as far as procedures for CRPS if you're lower extremity. So it's a good one. And then you just go from there. So
that's, once again, efficacy is variable depending on the patient, duration of symptoms, et cetera, et cetera. Pelvic pain, so the hypogastric ganglion, which sits at the front of L5, you can get at, and the ganglion impar, which you can basically you access it through the sacrococcygeal joint, which is a little joint right at the very bottom of your spine that joins your sacrum to your coccyx, and you go through that little joint, or you can go around the little joint as well to inject the ganglion impar. And you can use this to treat pain that comes from, endometriosis, dysmenorrhea, so painful periods, pain from prostatitis, things along those lines. I gotta be honest, I don't think they're super great for those things. I think there's a greater risk that you see a flare of pain in these patients afterwards. There's certainly some that respond super well, but I think there's a subgroup that with these injections, you can flare up afterwards, and then it starts to calm down after that.
Well, in these two, you're throwing at those prognoses that it's like, what else do you do?
Oh yeah,
with those pelvic pain presentations. So it's not that you're just throwing something against the wall and seeing if it sticks, but it's that it is a different application than I've seen with CRPS patients with that upper and lower extremity. I could see the pelvic response being quite different.
So it's much more
useful.
Pelvic pain specifically, I've started to go away from those for coccydynia. So coccydynia is painful coccyx. Dynia is pain.
Dynia of the coccyx.
Yeah. So we look at ganglion impar injections. In this setting, what you're doing is you've been injecting the sacrococcygeal joint, you inject the ganglion impar, and we do a caudal epidural at the same time. So the thought process we have there is you are treating the joint that is probably driving part of it, giving an inflammatory response. You've got your sympathetic nerves just on the inside that will be irritated by, the inflammatory stuff the joint is releasing. And then you've got the coccygeal nerves that are coming out of the very bottom of the spinal canal and then going down to supply the coccyx. And so we do what's called a caudal epidural at that point, because we're targeting those nerves at the same time. So you're getting the sensory supply, the joint itself probably driving the issue, and then the sympathetic nervous supply. Once again, there's not a ton of documented data on this. This approach, I find, works in enough people that I keep doing it. So
Yeah.
it's not a 1-for-1, but it's successful in enough people that they're like, yeah, that's sorted. Thanks very much. See you
Well,
later.
yeah, it makes the upside as likely as possible
Yeah.
when you're kind of
So
covering off on everything, and where someone is left after that
yeah.
will obviously still vary a lot depending on the other factors.
Yeah.
But yeah.
Risk with those ones, infection, bleeding, bruising. Interestingly, when you're doing this, you're very close to someone's bowel. So you've got to be very cautious about how you're
Yeah.
doing this. We're close to lots of things, so we're always cautious about what we're doing things. But, you can generally see the bowel, or you can see the bowel every time you're doing it. So it's pretty simple not to stick a needle in it.
Always good.
And, there is the risk. I've seen it once actually, where if you get abnormal spread, you can knock off some of the nerves to your pelvis and have some short duration of incontinence because your pelvic floor turns off. That lasts for the period of time where the local anesthetic is active, which is generally 2 to 4 hours, and then it goes away. So no long-term issues from that stuff.
Can I have a question?
Oh, hand up from Jazz.
Question. Yeah. So I've always found it interesting that with the sympathetic lumbar injections, when you get them, there is this, it's not so much that it's painful, it's that you feel this overwhelming pressure and weight. It's almost like an elephant's like sitting on your back when you're getting that. What creates or causes that sensation? Because for me, it was pretty different than other procedures and stab and jabs I've gotten. Is that personal to me, or do you see that across patient sets? Because it's a weird sensation.
Okay, so number one, like in Australia, we're nicer to our patients.
Oh yeah, you guys sedate them. Yeah, we're not.
Sleep.
Yeah, I'm awake for the whole thing.
You come in, tell me you're in agony, and I go, I get that. We can put you to sleep. It's not like in America where you go, well,
That's
too bad.
not the answer I wanted. Yeah. It's just, it is what it is.
Oh,
Yeah.
look here. I'll give it. So
weird.
getting away from the fact that Australians are nicer than the American doctors, what I would say is that when you're doing this, it sits at what you're actually injecting into is an area at the front part of the vertebral body, and right attached to that is a muscle called psoas. Okay. And so what you're actually doing is you're injecting between psoas, which is the muscle, and the bone. So I would imagine that as you're injecting in there's a large number of stretch receptors, and you put in quite a reasonable, large volume. Like you're putting in about 8 mils of fluid. And so as you're injecting, you'll be stretching a large amount of psoas fibers. So I imagine that will give you a pressure effect. If I'm going to do some physiological hypothesis generating.
I like that. Sounds good and plausible, because that's the interesting part of it is, yes, there's the pain of the initial anesthesia, and then there's that, and it is as they're pushing it in, and then it subsides.
So if you want to go with anecdotal stuff that I don't really know about, I can give you another one. So you can do pulsed radio frequency of these as well. And as part of the pulsed radio frequency, a lot of the time what you can do is you do sensory stimulation. So you actually stimulate the sympathetic ganglion and say, is that in the area of your pain? And interestingly, when you do stimulate the sympathetic ganglion, I've had a number of patients go, it just feels like it's in the middle of my leg. Like weird. The middle, not the outside. It's not on my calf, it's not my foot, it's not my base. It's in the middle of my leg. And I'm like, oh, that's really interesting. And so, from time to time, if people have given me that sort of description of pain, it makes me just think, oh, maybe there's a sympathetic component to this, because they've got this, you say, where's the pain? They just
weird.
Go, it's just in
the location
middle.
Sensory issue.
Yeah.
You can't pin it down.
Yeah. So, and it might be that, your brain is going, where's this
could just
coming
be brain
from?
Mapping.
I have no idea. I tell them it's in there.
Right. Like with visceral or organ pain, close enough, right? As opposed to stubbing your toe and exactly. That's the example you gave earlier. Yeah. All right.
There's two more things I'd like to talk about. So as I sort of mentioned before, I'm sort of going away from sympathetic ganglion blocks for pelvic pain, just because I think I see a little bit too many flares afterwards. What there is reasonable data around is posterior tibial nerve pulsed
Yeah.
and stimulation or pulsed RF. So who would have thought that the nerve that sits behind the bone on the inside part of your
Yeah.
ankle, you can stimulate to change pelvic plane. And so what ends up actually happening in this setting is that posterior tibial nerve, the way it's wired is into the sympathetic ganglion within your pelvis. And so you can stimulate it and it can decrease pelvic pain. And so there's quite a number of randomized controlled trials in cancer pain, endometriosis pain, painful periods, and prostatitis that show that if you do post-tib stimulation, that it actually decreases pain in those conditions. So
it's an indirect way to get to the pelvic pain while minimizing the flaring that you get when you go straight to the pelvis itself.
So I'm sort of starting to lean towards posterior tibial nerve stimulation. In the form I'm using pulsed radio frequency at this point in time, for which there's a little bit of data around that supports it. You started as unilateral, and that is a way of looking at doing these techniques. So once again, moderate levels of data to support its use. I like it because it's away from the area that you're actually, where the pain actually is. So
which is a huge barrier for highly flared patients. It's like, then it just makes everything worse. So
that's right. And I think that's probably the thing that's different, with pelvic sympathetics to others. Like with upper limb CRPS, you're going at a stellate ganglion lock. You're away from the pain. With lower limb CRPS, you're going at L3. You're away from the pain.
It's not my back. That's the problem.
With pelvic pain, you're going at the pelvic, and you're going
right at it.
You're right at it. You're in the target zone,
sense.
And it's not surprising that people flare
subset
up.
Flares.
So going to something like posterior tibial nerve stim or posterior tibial nerve injections are a logical way to sort of go away to have a crack at trying to settle some of that pain.
Circumvent the problem, but get as much as the upside.
There's one thing I didn't mention that it's called Splanchnic ganglion blocks. So the Splanchnic ganglion...
an extra credit one?
Oh, yeah, extra credit. So Splanchnic ganglion sits at T11 and T12, and you can use it to address neuropathic abdominal pain. And so it's generally... I don't see that much abdominal pain because
I was going to say that's a weirder.
Yeah, I don't. I do back, necks, and joints. So as
the business name alludes to.
As my 10-year-old says, Dad does. If you move it and it hurts, Dad looks after it. So abdomens don't walk through the door that much, but except attached to arms, legs, and backs. But for occasionally they do come, and so we do sympathetic ganglion blocks in that setting. Interestingly, with sympathetic ganglion blocks, because of the way your organs are supplied, you actually have to do bilaterally. So you do a bilateral T11, T12 Splanchnic ganglion blocks. And once again, it's a diagnosis by treatment approach, and you can then see if that settles down pain. And certainly I found that to be quite effective in a number of patients. There's another version which is called a celiac plexus block. I tend not to do them. Number one, I haven't learned the technique. Number two, my understanding of the technique is you've got to go through the aorta, which just makes me a bit weaky.
Yeah. Sounds fun.
Yeah. So, stick it at
pass.
That's a pass at the moment. So stick it
back neck
ganglion blocks.
Yeah.
And I do find, to be honest, for the right patient, Splanchnic ganglion blocks could be a wonderful way to then settle down abdominal pain. We also use them in this setting as an indicator for whether people respond to their neuromodulation for chronic abdominal pain. So there's some data around spinal cord stimulation and chronic neuropathic abdominal pain. Pretty much the way the data works is that you do a Splanchnic ganglion block first. If that's effective, you then go on to a trial of neuromodulation, which gives you, it increases the likelihood that you respond to the trial. You respond to the trial, you then go on to an implant. So, it gives you a treatment algorithm that you can work through as a means of trying to work out, chronic abdominal pain that's non-responsive to everything.
Is that true in the other settings as well? Like how for me, basically the positive response to the sympathetic lumbar injection, I still did a spinal cord trial, but it would indicate that someone would respond well or better to that therapy. Not the same. Yeah.
No.
Yeah. So only for this one.
Yeah.
Just still. Yeah. It's good. Yep. Cool. All right.
All
Anything
right,
else
there you
with
go.
these?
Sympathetic ganglion blocks.
Sweet. Yeah, no, this is a cool one. And again, if you're one of the complex, kind of weird patients, or you've tried a lot of things and you don't have a lot of options left, especially if you have that pre-existing bucket of trauma, PTSD, and you are presenting strongly with the sympathetic pieces of things, this is a good one and worth a try. And I've also worked with a fair amount of patients who have positive responses with it and just go into it with realistic expectations. Like Dan said, it's not going to work the same for everyone. It's not a magical cure. How much of your pain does it knock off varies. But in patients that don't have a lot of options, this is worth a try.
It's worth an option.
Good one. It's worth an option. Beggars can't be choosers. All right.
All right. Thanks, Jazz.
Anything else?
No.
All right, cool.
That'll do. That was a good one.
I like this one.
It.
All right. Thank you guys.
All right.
Enjoy. And we will see you on the next episode of It's Not In Your Head podcast. Take care.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.